In this video, we are going to discuss about electrocardiogram. An electrocardiogram is used to record electrical changes in the myocardium during the cardiac cycle using a machine known as an electrocardiograph. An ECG provides information about coronary circulation. The electrical impulse that travels through the heart can be viewed by means of electrocardiography, the end product of which is an electrocardiogram. Each phase of the cardiac cycle is reflected by specific waveforms on the screen of a cardiac monitor or on a strip of ECG graph paper. A rhythm is defined as 3 consecutive heartbeats displaying identical waveforms on the ECG. The similarity of the waveforms indicates that their origin is the same. The sinoatrial node is the heart's pacemaker under normal circumstances, and the rhythm is referred to as sinus rhythm. Print a copy of rhythms from one or more specific ECG leads over a set time called a rhythm strip. An action potentials stimulate cardiac muscle fiber contraction. A specific pattern appears. It is not the same as individual action potentials because body fluids conduct electrical currents. These electrical changes can be detected on the body surfaces. Ventricular rhythm exists if 3 or more consecutive beats have a ventricular origin. Now let us see how to obtain an electrocardiogram. An ECG is obtained by placing electrodes on the body at specific areas. Biomonitoring electrodes comes in various shapes and sizes but all have 2 components. An adhesive substance that attaches to the skin to secure the electrodes in place. A substance that reduces the skin's electrical impedance, facilitating the transfer of ions from the tissue to electrons in the electrode, enhancing the conductivity. Now let us see how to apply the electrodes. Gently abrading the skin with a clean, dry gauze pad helps to expose the inner conductive layer of epidermis, which will reduce skin impedance. Although cleansing the skin with alcohol removes any oily residue from the skin, it also increases the skin's electrical impedance and hinders detection of the cardiac electrical signal. If the amount of chest hair prevents the electrode from having good contact with the skin, the hair may need to be clipped. Poor electrode adhesion will cause distorted, irrelevant, and extraneous ECG waveforms, which may distort capturing an accurate ECG waveform. The monitoring system requires an adequate electrical signal to analyze the patient's cardiac rhythm. When applying electrodes, the recommendations should be followed to optimize skin adherence and conduction of the heart's electrical current. The recommendations are: wash the skin surface of dead cells with soap and water. Dry well using a washcloth or gauze. Clip hair from around the electrode site if needed. Do not shave. Connect the electrodes to the lead wires prior to placing them on the chest. Connecting lead wires when electrodes are in place may be uncomfortable for some patients. Peel the backing of the electrode and check to make sure the center is moist with electrode gel. Locate the appropriate lead placement and apply the electrode to the skin, securing it in place with light pressure. Change the electrodes every 24 hours. Examine the skin for irritation and apply the electrodes to different locations. If the patient is sensitive to the electrodes, use hypoallergenic electrodes. The number and placement site of the electrodes depend on the type of ECG being obtained. Most continuous monitors use 2 to 5 electrodes, usually placed on the limbs and the chest. These electrodes create an imaginary line called a lead, which serves as a reference point from which the electrical activity is viewed. A lead is like an eye of a camera. It has a narrow peripheral field of vision, looking only at the electrical activity directly in front of it. Therefore, the ECG waveforms that appear on the ECG paper and cardiac monitor represent the electrical impulse in relation to the lead. A change in the waveform can be caused by a change in the electrical impulse, where it originates or how it is conducted, or by a change in the lead. Electrodes are the adhesive conductive part that sticks to the skin. Lead wires are the color-coded wire that connects to the electrode and transmits electrical activity to the ECG machine. The electrodes are attached to cable wires which are connected to one of the following: an ECG machine placed at the patient's side for an immediate recording, that is a standard 12-lead ECG. A cardiac monitor at the patient's bedside for continuous reading. This kind of monitoring, usually called hardware monitoring, is used in intensive care units. A small box that the patient carries and that continuously transmits the ECG information by radio waves to a central monitor located elsewhere called telemetry. The primary benefit of using telemetry is that the system is wireless, which allows patients to ambulate while one or two ECG leads are monitored. The patient has electrodes placed on the chest with a lead cable that connects to the transmitter. The transmitter can be placed in a disposable pouch and worn around the neck, or simply secured to the patient's clothing. Most transmitter batteries are changed every 24 to 48 hours. A small lightweight tape recorder-like machine called ambulatory ECG monitoring, or a Holter monitor, that the patient wears and that continuously records the ECG, which is later viewed and analyzed with a scanner. Ambulatory electrocardiography. Ambulatory electrocardiography is a form of continuous or intermittent ECG home monitoring. It is used to identify the etiology of syncope or palpitation caused by dysarrhythmias, detect episodes of myocardial ischemia, evaluate effectiveness of treatment of heart failure and dysarrhythmias, as well as evaluate the functioning of ICDs and pacemakers. Several types of devices are available and are worn either externally or implanted under the skin. The ECG is transmitted to a centralized monitoring station via telephone. Newer devices transmit ECGs through the use of wireless technology to a secure website. ICD means it is an implantable cardioverter defibrillator, a small battery-powered device placed in the chest that detects and stops irregular heartbeats, also called arrhythmias. It continuously checks the heartbeat and delivers electric shocks when needed to restore a regular heart rhythm. Next is continuous monitors, commonly called Holter monitors. These small portable recorders are connected to chest electrodes that record the ECG using several leads onto a digital memory devices. The number varies based on model used. The patient wears the recorder for 24 to 48 hours and in certain cases up to 2 weeks. If the patient experiences symptoms, they are instructed to activate the event marker. The patient is also asked to keep a diary to note the date and time of symptoms or performance of unusual activities. The diary is used by the primary provider to correlate symptoms with detected dysarrhythmias. Once monitoring is completed, the patient returns the device to the primary provider's office. Data from the digital memory device are then uploaded into a computer for analysis, and rhythms that need further evaluation by the primary provider are identified. The effectiveness of this form of monitoring is dependent upon the patient's adherence with keeping a diary and marking events. The placement of electrodes for monitoring varies with the type of technology, the purpose of monitoring, and the standards of the healthcare facility. For a standard 12-lead ECG, 10 electrodes, 6 on the chest and 4 on the limbs, are placed on the body. To prevent interference from the electrical activity of skeletal muscle, the limb electrodes are placed on areas that are not bony and that do not have significant movement. Now let us see where to place an electrode in continuous electrographic monitoring. Standard 3-wire lead placement. Place the white electrode just below the patient's right clavicle. Place the black electrode below the patient's left clavicle near the shoulder. Place the red electrode below the patient's left pectoral muscle near the apex of the heart. Standard 5-wire lead placement. Place white, black and red electrodes in same position as 3-lead electrode. Place green electrode opposite the red electrode. Place brown precordial electrode to the right of the sternum border in the 4th intercostal space. Now let us see chest electrodes and placement. V1. V1 is placed on 4th intercostal space on the right sternum. V2 is placed on 4th intercostal space at the left sternum. We will skip right now V3. V4 is placed 5th intercostal space at the mid-clavicular line. V3 is placed midway between placement of V2 and V4. V5 is placed on anterior axillary line on the same horizontal level as V4. V6 is on mid-axillary line on the same horizontal level as V4 and V5. Now let us see where to place the limb electrodes. RA, that is to right arm, anywhere between the right shoulder and right elbow. RL, that is to the right leg, anywhere below the right torso and above the right ankle. LA, that is to left arm, anywhere between the left shoulder and the left elbow. LL, left leg, anywhere below the left torso and above the left ankle. When we place the electrode, it should be symmetrical. Now we'll see modified 12-lead ECG placement. Placing the limb electrodes and lead wires on the torso instead of the extremities. Placing limb electrodes on the torso may be necessary for an amputated extremity, infants to reduce motion, and the patient who is having excessive limb movement. It is important to note studies have suggested potentially significant changes to the ECG morphology when the limb electrodes are placed on the torso. As a result, if the limb electrodes are placed on the torso, then it is good practice to notify the provider and write torso positioned limbs on the ECG. There are 3 sets of leads. Standard limb or bipolar leads, that is lead 1, lead 2, lead 3, utilizes 3 electrodes. These leads form a triangle known as Einthoven triangle. Next is augmented unipolar limb leads, AVR, AVL, AVF. Then precordial unipolar leads, that is V1, V2, V3, V4, V5 and V6. Now we'll see the relationship of electrocardiographic complex lead system and electrical impulse. The heart conducts electrical activity which the ECG measures and shows. The configurations of electrical activity displayed on the ECG vary depending on the lead or view of the ECG and on the rhythm of the heart. Therefore, the configuration of a normal rhythm tracing from lead 1 will differ from the configuration of a normal rhythm tracing from lead 2. Lead 2 will differ from lead 3 and so on. The same is true for abnormal rhythms and cardiac disorders. To make an accurate assessment of the heart's electrical activity or to identify where, when and what abnormalities occur, the ECG needs to be evaluated from every lead, not just from lead 2. Now let us see components of electrocardiogram. The ECG waveform reflects the function of the heart's conduction system in relation to the specific lead. The ECG offers important information about the electrical activity of the heart and is useful in diagnosing dysarrhythmias. ECG waveforms are printed on graph paper that is divided by vertical and horizontal lines at standard intervals. Time and rate are measured on the horizontal axis of the graph and amplitude or voltage is measured on the vertical axis. The electrical events of the heart, that is ECG, are usually recorded as a pattern of a baseline, that is isoelectric line, broken by a P wave, a QRS complex, and a T wave. In addition to the wave components of the ECG, there are intervals and segments. The isoelectric line is a point of departure of the electrical activity of depolarizations and repolarizations of the cardiac cycles and indicates periods when the ECG electrodes did not detect electrical activity. An interval is a time measurement that includes waves and or complexes. A segment is a time measurement that does not include waves and or complexes. When an ECG waveform moves toward the top of the paper, it is called a positive deflection. When it moves toward the bottom of the paper, it is called a negative deflection. When reviewing an ECG, each waveform should be examined and compared with the others. Nodes are placed on the skin and connected by wires to the electrocardiograph. Typically, tall leads or electrodes are used that respond to weak electrical changes by moving a pen or stylus on a moving strip of paper. The regular movement of the paper allows the distance between the pen movements to record the time between phases of the cardiac cycle. 3 of the electrodes are bipolar leads. They measure voltage difference between both arms or between one arm and one leg. 9 of the electrodes are unipolar leads. The total of 12 leads provide a complete picture of the electrical activity of the heart. A normal electrocardiographic pattern includes several waves or deflections during each cardiac cycle. In between, muscle fibers remain polarized and the pen does not move except for indicating the baseline reading. Now we'll see ECG graph and commonly measured components. Each small box represents 0.04 seconds on the horizontal axis and 1 mm or 0.1 millivolt on the vertical axis. The ECG is composed of waveforms including the P wave, the QRS complex, the T wave and possibly a U wave, and of segments and intervals including the PR interval, the ST segment and the QT interval. As the SA node triggers an impulse, the atrial fibers depolarize to produce a recordable electrical change. The first pen movement produces a P wave that shows the depolarization of the atrial fibers leading to atrial contraction. The P wave represents the electrical impulse starting in the SA node and spreading through the atria. The P wave is the first positive deflection and represents atrial depolarization or atrial contraction. The normal amplitude of the P wave is 3 mm or less. The normal duration of the P wave is 0.04 to 0.11 second. P waves that exceed these measurements are considered to deviate from normal. As the impulse reaches ventricular fibers, they quickly depolarize, showing a greater electrical change because of the thicker ventricular walls. When the change ends, the resulting mark is called the QRS complex, consisting of a Q, R and S waves that correspond to the depolarization of ventricular fibers before ventricular contraction. The QRS complex has an intricate shape because there is a constant change in the paths of depolarization waves through the ventricular walls. Atrial repolarization or relaxation occurs during the QRS complex but cannot be seen. The QRS complex contains separate waves and segments which should be evaluated separately. The QRS complex is normally less than 0.12 seconds in duration. The Q wave is the first negative deflection after the P wave. The Q wave or first downward stroke after the P wave is usually less than 3 mm in depth. A Q wave with significant deflection is not normally present in the healthy heart. A pathologic Q wave usually indicates a completed MI. The Q wave is normally less than 0.04 seconds in duration and less than 25% of the R wave amplitude. The R wave is the first positive deflection after the P wave, normally 5 to 10 mm in height. increases and decreases in amplitude become significant in certain disease states. Ventricular hypertrophy produces very high R wave because the hypertrophied muscle requires a stronger electrical current to depolarize. The S wave is the negative deflection after the R wave. As the ventricles repolarize, a T wave is produced and recorded. Atrial repolarization is missing from the pattern because atrial fibers repolarize at the same time the ventricular fibers are depolarizing. The T wave lasts about 0.16 seconds because repolarization is slower than depolarization. The T wave appears more spread out with a lower amplitude height than the QRS complex. It is often obscured by the larger QRS wave being recorded simultaneously. The T wave represents ventricular repolarization when the cells regain a negative charge, also called the resting state. It follows the QRS complex and is usually the same direction or deflection as the QRS complex. Atrial repolarization also occurs but is not visible on the ECG because it occurs at the same time as ventricular depolarization, that is the QRS. The T wave follows the S wave and is joined to the QRS complex by the ST segment. The ST segment represents ventricular repolarization or relaxation, the point that represents the end of the QRS complex, and the beginning of the ST segment is known as the J point. The T wave represents the repolarization of myocardial fibers or provides the resting state of myocardial work. The T wave should always be present. Normally, the T wave should not exceed a 5 mm amplitude in all leads except the precordial V1 to V6 leads, where it may be as high as 10 mm. The T wave represents the return of ions to the appropriate side of the cell membrane. This signifies relaxation of the muscle fibers and is referred to as repolarization of the ventricles. Electrocardiographic patterns are used to assess the heart's conduction of impulses. The PQ interval is the time period between the P wave and the QRS complex and can indicate impulse transmission times between the SA node and AV node to indicate ischemia or other conditions that affect the AV conduction pathways. Damage to the AV bundle can extend the QRS complex, showing a different recording on an ECG. The PQ interval takes about 0.16 seconds and is also referred to as the PR interval if the Q portion is not visible. The PR interval represents the time it takes for the electrical impulse to travel from the SA node to AV node and down the bundle of His to the right and left bundle branches. The PR interval includes atrial depolarization, contraction, and the passage of the depolarization wave through the remainder of the conduction system. The PR interval is measured from the upstroke of the P wave to the QR junction, represents the time needed for sinus node stimulation, atrial depolarization, and conduction through the AV node before ventricular depolarization and is normally between 0.12 and 0.20 seconds. There is a built-in delay in time at the AV node to allow for adequate ventricular filling to maintain normal stroke volume. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. The QR complex is measured from the beginning of the Q wave to the end of S wave. The QT interval is measured from the beginning of the Q wave to the end of the T wave, and the TP interval is measured from the end of the T wave to the beginning of the next P wave. The ST segment begins at the end of the S wave, the first negative deflection after the R wave, and terminates at the upstroke of the T wave. The ST segment, which represents early ventricular repolarization. The beginning of the ST segment is usually identified by a change in the thickness or angle of the terminal portion of the QRS complex. The end of the ST segment may be more difficult to identify because it merges into the T wave. The ST segment is normally isoelectric. It is analyzed to identify whether it is above or below the isoelectric line, which may be, among other signs and symptoms, or a sign of cardiac ischemia. The ST segment occurs when the action potentials of the ventricular myocytes are in their protophases. At this time, all the ventricular myocardium is depolarized. The QT interval is the time between the Q wave and the T wave. It represents ventricular depolarization, that is contraction, and repolarization, that is relaxation, is measured from the beginning of the QRS complex to the end of the T wave. The QT interval varies with heart rate, gender, and age. Therefore, the measured interval needs to be corrected for these variables through specific calculations. The QT interval lasts about 0.38 seconds. It is the period from the start of ventricular depolarization through ventricular repolarization. The QTC may be automatically calculated by the ECG technology, or it may manually calculate or use a resource that contains a chart of these calculations. The QT interval is usually 0.32 to 0.40 seconds in duration if the heart rate is 65 to 95 beats per minute. Many medications commonly given in the hospital can cause prolongation of the QT interval, that is QTC, placing the patient at risk for a lethal ventricular dysarrhythmia called torsade points. The U wave is thought to represent repolarization of the Purkinje fibers. Although this wave is rare, it sometimes appears in patients with hypokalemia, that is low potassium level, hypertension, or heart disease. If present, the U wave follows the T wave and is usually smaller than the P wave. If larger in amplitude, it may be mistaken for an extra P wave. The TP interval is measured from the end of the T wave to the beginning of the next P wave, that is also called an isoelectric period. When no electrical activity is detected, the line on the graph remains flat. This is called the isoelectric line. The ST segment is compared with the TP interval to detect ST segment changes. The PR segment is sometimes used to determine the isoelectric line. However, sometimes it is altered due to ischemic conditions. The TP interval is the preferred reference for the isoelectric line. The PP interval is measured from the beginning of one P wave to the beginning of the next P wave. The PP interval is used to determine atrial rate and rhythm. The RR interval is measured from one QRS complex to the next QRS complex. The RR interval is used to determine ventricular rate and rhythm. Now let us see how to determine heart rate from the electrocardiogram. Heart rate can be obtained from the ECG rhythm strip by several methods. A 1-minute rhythm strip contains 300 large boxes and 1500 small boxes. Therefore, an easy and accurate method of determining heart rate with a regular rhythm is to count the number of small boxes within an RR interval and divide 1500 by that number. If, for example, there are 10 small boxes between two R waves, the heart rate is 1500 divided by 10, that is 150 beats per minute. If there are 25 small boxes, the heart rate is 1500 divided by 25, that is 60 beats per minute. We can thus calculate heart rate by dividing 300 by the number of large squares between each RR interval. Heart rate is equal to 300 divided by the number of large squares. For example, if there is one large square between R waves, the heart rate is 300 beats per minute. If there are two large squares, the heart rate will be 150 beats per minute. An alternative but less accurate method for estimating heart rate, which is usually used when the rhythm is irregular, is to count the number of RR intervals in 6 seconds and multiply that number by 10. Number of RR intervals in 6 seconds into 10. The top of the ECG paper is usually marked at 3-second intervals, which is 15 large boxes horizontally. The RR intervals are counted rather than QRS complexes because a computed heart rate based on the latter might be inaccurately high. The same methods may be used for determining atrial rate using the PP interval instead of the RR interval.